think this discussion always starts off with sort of understanding disease definitions. And I've done a number of these sessions before with patients and providers. And the reality is that there's not really a clear understanding yet of what compromises this space for patients. What kind of patient characteristics are important to understand if you have intermediate risk, low-grade, non-muscle invasive bladder cancer. And part of that is because we haven't had a lot of treatments before besides TURBT, which is to remove or excise the entirety of a bladder tumor that does require a general anesthesia. You have to hold your blood thinners typically. Some patients require a catheter afterwards. But that operative procedure has been the mainstay of managing really all bladder cancer for the past several decades. So sort of right there, you have an unmet need for something that doesn't require patients to go to the operating room, again, hold their blood thinners, and then be potentially subjected to an operative procedure. But I think it's really important to understand what intermediate risk non-muscle invasive bladder cancer is. And when we talk about low-grade patients specifically, we're talking about a disease type that is really sort of most characterized by recurrence and a smaller risk of what's called progression. Progression means either going to high-grade disease or going to invasive disease, and both of those are more worrisome prognosis for patients. Recurrence is more about sort of repetitive treatments that sort of can sometimes wear down a patient, both psychologically and also even surgically, having to go to the operating room very frequently. I think the most common definitions that we use are patients who are recurrent, typically within a year of the last time they had a tumor. Patients who have multiple tumors, we call multifocal disease. So when you look in, there's more than one tumor that's present, or a large tumor, and that's really defined by being bigger than 3 centimeters. So I always think about the intermediate low-grade space as being either large, greater than 3 centimeters, multifocal, or recurrent. And I think that's sort of an easy paradigm way to think about this disease space. As I mentioned, really up until June, with the FDA approval of a new agent called Zosduri, historically the treatment has always been TURBT, remove the bladder tumor, and then for some patients using some sort of bladder washing medication, most commonly done with chemotherapy, especially now that we have BCG shortages, or BCG to sort of work on recurrence and trying to minimize recurrence. So the initial treatment is always surgical, and then using medications to wash the bladder with a catheter afterwards to try to prevent recurrence. In a small number of patients, we may observe very small recurrences and wait for them to either get larger or more multiple, especially in our sicker patients. And then the other alternative is something called office fulguration, which again is really best designed for smaller tumors. This is done while patients are awake, with the idea of just sort of cauterizing small recurrences rather than taking patients back to the operating room. But I would say the fundamental recommendation is really TURBT or surgical excision. And again, that with its inherent issues of requiring anesthesia, stopping some medications, and then undergoing a surgical procedure that has implications for the patient as well as their family who has to drive them home, sometimes help watch these patients. There's really been an unmet need for trying to limit the number of recurrences to sort of minimize this repetitive burden of this type of illness. And so those are really kind of the two mainstays for this low-grade intermediate risk space. So now we have two. As of June, a new drug was approved called Zosduri, and I'm going to spend a little time talking about that because it's really a completely unique way of treating bladder cancers that's going to be new to urologists. So the idea of Zosduri is a concept called topical chemoablation. The idea here is that you can put a medication into the bladder and it will actually dissolve away the tumors without requiring a TURBT. That is, without requiring anesthesia, without requiring an excision surgically of removing the tumors. Zosduri is a topical treatment. It's administered via a traditional urethral catheter. It's done in our offices the same way that we give many, many agents in the bladder. It's given once a week for 6 weeks. Patients can certainly drive themselves back and forth to each visit. And then we check the bladder about 6 weeks later. The complete response rate on the clinical trial that was the main factor for Zosduri receiving its approval, called Envision, demonstrated over 79% of patients had a complete response to topical chemoablation, meaning that they had a tumor seen in the bladder. These are patients who had recurrent disease, so they previously had a low-grade bladder cancer and then recurred. And we saw that in over 79% of patients, when you just put a topical gel into the bladder with no resection, almost 4 out of 5 patients will have no tumor left behind at 3 months. And so this is a very new and obviously very different way of addressing tumors, not requiring our surgical excision TURBT, which has been the mainstay for really the entirety of urology But now, as of the last 2 months, a new and novel approach to bladder tumor management in the recurrent low-grade intermediate risk space. So you now have got, on one hand, a surgical option, and the other hand, you've got a non-surgical option. And I think with a really high degree of effectiveness. I think very importantly, it's not only effective at 3 months, but patients who are on Envision have now been studied out to 24 months, and we'll talk a bit about those data. But we can see that when patients were looked at a year or 15 months, over 80% of patients were estimated to maintain that complete response with just the first 6 treatments. There were no maintenance treatments on Envision, meaning that patients got 6 treatments and then just observed every 3 months with the cystoscopy. And now that we're seeing that over 72% of patients will maintain that complete response out to 2 years. And remember, really interestingly, these are patients that have recurrent bladder cancer. That's how they got into the Envision study. And so by definition, they're patients who are typically going to recur. But we saw on Envision that even with just that single round of treatments 2 years prior, for those patients that were responders, over 72% of patients actually could maintain that response with no additional treatment on all subsequent cystoscopies. So really kind of now we have 2 treatment options. And I would argue these are the 2 mainstays of treatment. There's always the approach, as we talked about, of using bladder washing after TURBT, either right afterwards, meaning within the first 24 hours with either gemcitabine or mitomycin, or to give it once a week for 6 weeks. But we've seen that the overall adoption for these types of treatments have been relatively low in the United States. The data supporting their use demonstrates that about somewhere between 20 to 50% of patients, depending on the study you look at, are undergoing these types of treatments following TURBT. So again, they're available but not highly utilized. But those would kind of be used in conjunction with TURBT. The Zosturi medication was not studied with any adjuvant treatment, meaning that patients, once they received their first initial 6 treatments over 6 weeks, had no other medications put into the bladder afterwards when just observed. So again, you've got 2 new treatment options, or 1 new treatment option, kind of to pair with our existing historical treatment option. And I think this really sort of opens up a lot of opportunities for patients and for providers to think about which patients are the best and which are not. I think clearly there's going to be a subset of patients where not going to the operating room and trying something topically makes sense. These are clearly our sickest patients. Bladder cancer is a disease of older patients. In general, the average age is about 75. The number 1 risk factor for bladder cancer is smoking. So many patients, unfortunately, by the time they're 75 and have had a smoking history, will develop lung disease or heart disease. These patients obviously carry a higher risk of going to the operating room, going under anesthesia. If they have heart disease, many of these patients are on blood thinners. I sometimes have days where all of my patients are on blood thinners, and these generally have to be discontinued or held to do a surgical treatment. And that obviously puts the patients at risk for a heart attack or a stroke or something else where they're worried about starting or stopping these medications, and also puts them at risk for having bleeding after the operation when they resume these blood thinners. So those patients, the ones that have higher operative risk, who are older and more frail, I think clearly allowing these patients to simply come into the office and receive a catheter-based treatment is sort of, I think, a very easy place to start for many of us. I also have patients, and I think almost all urologists do, where the disease is either just so extensive, meaning there's 10, 20, 30 tumors in the bladder that just removing and trying to excise every tumor has not historically been successful. And these are very multifocal tumors. And some of these patients, but others, they also just keep recurring. And so we look in, we cut out what we see, and then we look in 3 months or 6 months later, and they always have another bladder tumor. I think that's the limitation of TURBT, is that you can only cut out what you see. And so some of these recurrences probably are there. They're probably tiny, and we just can't see them yet under cystoscopy, whether you use white light cystoscopy or even blue light cystoscopy. And what happens is, because you haven't cut them out because you can't see them, after a few more months, they become big enough to see. We call that a recurrence. But they may have been there on the initial cystoscopy, but just not visualized. That's one of the really nice things about these topical chemoablation treatments like Zosturi, is that you are treating the entire urinary lining. The gel is put into the bladder. It's a really interesting sort of a way in which the drug was designed. When you chill the drug, it becomes a liquid. So it's sort of the opposite of ice, right? Water, when we chill it, becomes solid. When you chill Zosturi, it becomes liquid. You then instill it cold into the patient's bladder. It warms there within a minute or two, and it forms the semi-solid gel that basically adheres to the entire lining of the urinary system. And so this gel type treatment basically covers the entire urinary lining. And so even those tumors that you haven't seen yet, they're getting gel treatment. And so it's not just the ones you see, but even the ones you don't see. The really nice thing about these gels is you can't really void them out. So unlike mitomycin or gemcitabine we give after surgery or we give in the office, those are called aqueous solutions. And so once patients void, they also urinate out the medication. They void out the chemotherapy agent. And for many of our older patients, they can't hold these drugs for that long. So they might get 30 minutes, an hour, maybe even 2 hours if we're lucky. But once that drug is voided out, it's no longer effective. These gel treatments basically coat the urinary lining and maintain contact for about 4 to 6 hours. And patients can void during that time. They don't have to stay in the office. They don't have to turn side to side. They can leave really immediately following the treatments. And that adherence to the wall of the bladder really changes this from an adjuvant treatment with mitomycin to a primary treatment with mitomycin. That contact time seems to be the key. Getting 4 to 6 hours of constant contact of chemotherapy to a tumor basically causes it to dissolve away. And so that's really sort of the novel aspect of this treatment. So again, patients who have tumors that coat lots of different parts of the bladder, including hard parts for us to reach, the gel is going to touch those. Patients who have highly recurrent disease where it just keeps coming back, and again, you're probably just not seeing them yet. I don't think any of us are capable of seeing the smallest tumors, but the gel is going to treat those too. And then, of course, the final group of those patients who are more frail, clearly those are patients we worry about taking to the operating room or have already had complications. Those are, I think, are easy patients as well. But really, one can argue with when almost 80% complete response rate and a durable response rate, which I think exceeds that of TURBT, that you don't really have to reserve this kind of in the background or in your back pocket for certain patients. It really can be offered alongside TURBT for any recurrent low-grade intermediate risk patient.